Hello, everyone, and thank you for joining. I'm Cleary and delighted to be supporting this work. I'm here today with Vala from the Middlesex London Ontario Health Team and Dr. Devon Shewfelt, a family physician and executive member of the Middlesex London Primary Care Network. Today, we're going to be talking to you about the IPCT expansion proposal, Interdisciplinary Primary Care Team expansion proposal, and specifically about the hub and spoke community health home model. We are very excited to work together on a collaborative proposal to expand integrated primary care teams across Middlesex London. This is an opportunity to work closely with our partners to really think about how we can improve access to primary care across Middlesex London and work towards achieving 100% attachment by 2029. We currently have over 94,000 individuals in this region who do not have access to a continuous primary care provider. The good news is that there's a funding opportunity right now that provides an opportunity to expand access to primary care teams in order to increase attachment. And this may include embedding principles of a neighborhood health home model. We've previously discussed the interdisciplinary primary care team expansion proposal in more detail in the first episode of this series. So we encourage you to go watch that. And today we're going to discuss more detail about the neighborhood health home model to get us thinking innovatively about how services might be delivered. A neighborhood health home model is rooted in primary care with strong connections to community support services, home care, mental health care, and more. Its services are built to meet the unique population needs. Earlier this year, we hosted a couple of engagement sessions to learn about the neighborhood health home model and discuss what principles we would want to embed into our primary care community. This includes having centralized intake and triage supports to make sure patients are connected to the right provider. We talked about enabling health and social providers to work together to deliver culturally safe and community-driven care. We talked about ensuring seamless person-centered care and navigation across settings, and that care should be available virtually, in person, in the community, and offered through mobile supports. We talked about the need and importance of equity inclusion, guiding care design and delivery, and working together effectively as a team, which should be supported by integrated technology and shared care records so that the whole interdisciplinary team has access to the patient files and care plans. We need sustainable funding and infrastructure and need to work collaboratively where everybody works to their full scope and understands each other's roles. And lastly, we need continuous evaluation to ensure services provided meet the unique needs of the community. Here you'll see a slide that provides a high-level visual of the hub and spoke model that we're considering. There is potential to identify existing primary care teams that would be considered our hubs, and these hubs would provide supports to providers within that hub as well as to the providers sitting outside of that hub. Spokes then, which you'll see on the right-hand side of the slide, could be existing family health organizations or solo physicians that would be connected to the hub, and the hubs would provide access to centralized intake support that would help attach patients to providers, clinical triage that ensures patients are scheduled to meet with the right provider at the right time for the right level of support, access to an interdisciplinary team, including navigators to community and social supports, referral supports, evaluation and quality improvement support, and coordinated after hours. We're going to explore these in more detail in the following slides. In terms of central intake, we understand that patients who have been unattached for some time can have complex care needs or unidentified needs. These patients may require a number of appointments with a number of different providers to identify and manage these needs and complete an accurate patient profile. We're exploring the idea of providing support for this attachment process, whereby a team in the hub would complete all required paperwork and conduct the initial intake assessment. This may involve personalized care planning, developing the cumulative patient profile, conducting a medication reconciliation, and bringing screening and immunizations up to date. Through this process, we would be developing a better understanding of the needs and complexities of the individual and support attachment to the most appropriate primary care provider, as well as enabling a balanced caseload. In terms of clinical triage, we recognize that right now, family physicians and nurse practitioners are often the first port of call and can be managing patient concerns that could be addressed elsewhere. We're exploring the idea that there could be triage at the point of scheduling to refer patients to the most appropriate care provider. This would require the use of standardized tools and comprehensive training to ensure triage is conducted appropriately and patients are seeing the right provider at the right time. Communication back to the most responsible provider will be an essential component of this process. In terms of access to an interdisciplinary care team, we've heard that this sort of access varies quite a lot in our community, with some patients not having any access to a continuous primary care provider, being a nurse practitioner or family physician. Some patients have access to a primary care provider or nurse practitioner, but not to interdisciplinary team-based supports. And then some patients have access to both a primary care provider or nurse practitioner and access to interdisciplinary supports. Ideally, through this model, we'd want to work towards all individuals in Middlesex, London having access to both an interdisciplinary team and being attached to a primary care physician or nurse practitioner. If you are located in a spoke, your patients would have access to an interdisciplinary team through the hub. The team, though, may also be co-located in the spoke at times, but if you do not have this space, then they would be located in the hub. In terms of referral and navigation support, we understand that services are ever changing and a lot of time is spent trying to identify the right services, completing the right referral forms, and following up on these referrals. We're exploring having a navigation referral coordination support team. In terms of navigation, they could identify the appropriate services and programs that your patients may require. They could also support social prescribing, including connecting patients to community supports or activities or other resources that may enhance their overall well-being. The referral coordination support would support with completion of referral forms, sending the referrals, following up on the referrals, tracking the referrals, and managing and rerouting referrals as required. Again, this level of support, the referral and navigation support, will require consistent and ongoing updates to the most responsible provider. In terms of evaluation and quality improvement, this is one of the core principles of a community health home. And through the evaluation, co-design, and quality improvement supports, the hub and spoke model could help you understand the unique needs of your patient population and how you could evolve your services over time. And we could evolve our services over time to meet those needs. Coordinated after hours could also be provided through the hub to ensure better access, more equitable access across the entire system, and to help ease the burden on emergency departments. And lastly, we understand that rural communities require a unique approach to increasing access to care. Considering a hub model, the hub may facilitate access to virtual care, transportation support, and support the delivery of care closer to home through a mobile clinic or having primary care spokes located in rural communities. I'm now going to hand over to Dr. Devon Shewfelt to talk a bit more about the opportunity in front of us.
Thanks so much, Connor. I've been practicing in a team for nearly 10 years, and my passion for the work that brings me here to you today really comes from a truly deep desire for all of my colleagues to get an opportunity to enjoy the same supports, resources, and really thus quality of life that I've been fortunate enough to have in this model of care. So this is the opportunity. We hope to create hubs that can provide supports to their providers and reducing administrative burden and increasing time for the direct patient care that we so value. This is for providers that are practicing within the hub as well as within associated spokes. Would access to such hub supports increase your capacity to attach more patients? That is the big question. Through this funding opportunity and submission process, we see an opportunity for existing primary care teams to add additional roles to their teams and become a hub. We see an opportunity for existing FOs and solo physicians to become spokes and thereby get access to hub supports. We also see an opportunity to create new spokes in areas with high level of unattachment, high marginalization, and limited existing primary care supports. With that said, please make sure you take the time to watch the next video that will highlight the geography across Middlesex, London, and give us insights into the levels of unattachment, marginalization, as well as location of existing primary care supports across our neighborhoods. We want to understand both the demand for primary care and the current supply, and use the data to guide our system plans to achieve 100% attachment by 2029. Let's work smart and work hard. Lastly, we want to invite you to join the Middlesex London IPCT expansion proposal. We ask you to please email hello@mlpcn.ca if you have any questions or you want to be put in contact with one of the physician leads, and also to ensure that you're looped into all future communication and engagement. This really is a once in a generation opportunity to shape the future of primary care in our region the way we want to. Together, we can build a system that we all want to work in that meets the needs of both providers and patients. We truly look forward to partnering with you.
Thanks, everyone.